In this video, we're going to cover 4 seemingly unrelated bacterial organisms: Bartonella bacilliformis, Bartonella hensleyii, Bartonella quintana, and Coxiella burnetii. What these bugs all have in common is that they're all atypical bacteria. Atypical bacteria are still bacterial organisms, but they don't cover or adhere to the standard replication or structural parameters that we associate with most bacterial organisms. So we're going to start with the organism Bartonella bacilliformis. This is the causative agent of carrion disease. This disease is pretty much restricted to the Andes Mountain regions of Peru, Ecuador, Colombia. That area is pretty much the only place that you're going to run into Bartonella bacilliformis. Potentially you'll see cases here if it's a travel case. And this is because of the vector that basically spreads Bartonella bacilliformis. The vector is endemic to this area, and it's the sandfly, or phlebotomus. The disease has 2 distinct stages. The first stage is called Aroya fever. This is basically an acute hemolytic bacteremia. It consists of fever, headache, myalgia, abdominal pain, and then severe anemia. The stage of disease ends as the humoral immunity increases. So as we have more antibodies to protect us, this stage of disease comes to a close. During the chronic stage of disease, though, carrion disease is what we experience. And in this case, you get these 1 to 2 centimeter cutaneous nodules, and they're often engorged with blood and appear over the course of 1 to 2 months. And they can actually persist for a long time, months to years. The nodules are called Verruga peruana, which you can see here in a picture from the New England Journal of Medicine. And the link between the Verruga peruana and Aroyo fever was actually demonstrated by a medical student named Carrion, which sounds great, except until you realize that this particular student decided to infect himself with aspirates from skin lesions from patients with Verruga peruana, and unfortunately he died of Aroyo fever. So do not infect yourself with aspirates from skin lesions of patients with unknown illnesses. The treatment for Aroyo fever is actually ciprofloxacin. In patients who that is not indicated for, like pregnant women and children, you can actually use amoxicillin with clavulanic acid. And just for the Verruga peruana, you actually use azithromycin. All right, the next 2 species we're going to cover are also Bartonellas, Bartonella hensleyii and Bartonella quintana. Bartonella hensleyii is known as cat scratch fever. The actual name for this is Bacillary angiomatosis, but cat scratch fever is a lot more fun to say. So the reason it's called cat scratch fever is actually cats are to blame for this. It's actually cats and their fleas that serve as the reservoirs for this. And they are asymptomatic carriers. So the cats are not sick, but their scratch could make you sick. So the disease is transmitted with their scratches or bites, or coming in contact with contaminated feces of the cat's fleas. So not changing your cat's litter box, but if the cat has fleas, then you can come in contact with it. So what does it cause? It causes this chronic regional lymphadenopathy of the draining lymph node, which you can see in this image here behind this individual's ear. It can also be disseminated to the liver and the spleen or the eye or the central nervous system. And where it becomes a really important pathogen, specifically we saw a lot of this in the 80s prior to good treatment, is in the HIV and AIDS population. In patients who are immunosuppressed, this can become a really severe disseminated disease. And what you'll get is this bacillary angiomatosis, which I'm showing here, which is basically where you get formation of blood vessel-filled lesions as nodules, and they form under the skin like this, and it's very painful and very disfiguring. In patients who are not immunocompromised, this is typically a self-limited infection. However, about 5 to 14% of patients will experience disseminated disease. So if you identify it, you're going to treat it anyway, even though it can be self-limited. Standard of treatment currently is azithromycin. But for patients who have splenic or hepatic involvement, you're going to add in rifampin with either azithromycin or gentamicin. The next organism we'll talk about is B. quintana. This is actually the causative agent of trench fever, which was something that was very prevalent in World War I, where trench warfare was very common. Typically, it presents as patients with having severe headache, fever, weakness, and pain in the long bones, particularly the tibias. You get it from the feces of the human body louse. So once again, this is something that we could associate with patients who are spending a prolonged period of time in pretty rough conditions like trenches, refugee camps, times of war. And the disease is literally spread person to person because people are living in close quarters. It can also lead to recurrent fevers and also can lead to bacillary angiomatosis in immunocompromised patients. Thankfully, this one doesn't happen all that often, so there currently aren't any good treatment recommendations for B. quintana. All right, the last organism we're going to talk about in this video is Coxiella burnetii. This is a slowly replicating intracellular pathogen. This is actually the main pathogen of the Coxiella genera, and it's the causative agent of Q fever. It's called Q fever because it used to be known as Querry fever. It was named this because it was not identified in its initial investigation. There was an outbreak of this in Australia, and they did a whole investigation and they couldn't identify the causal organism. And part of that is because it's so slowly replicating and it's an intracellular pathogen. So normally when we're looking for bacteria, we streak it on a plate. You're only going to be looking for an intracellular pathogen if you think it's a bacteria, and then you think it's a virus. And even if you do think it's a virus, you need to know which cells it's going to infect intracellularly. So these intracellular pathogens can actually be a little more difficult to identify. It's able to regulate the cell signaling pathways of the cells it infects, which are typically phagocytic cells like macrophages and monocytes. And because it regulates this intracellular signaling, it actually delays the death of the cell while it's inside it. It's an extremely stable organism. It can survive in soil and dairy like milk for years. I don't know why you would keep milk around for years, but if you do, it's possible that C. burnetii could theoretically be in it. And how would it get there? Well, it's found in mammals and birds and a whole bunch of different species of ticks. So it's somewhat prevalent. And human infection can actually also occur just by inhalation of airborne particles from a contaminated source, like unpasteurized milk in dairy workers. So think about this: if you're in a dairy facility and milk becomes somehow aerosolized, you could just breathe it in. But this is not a tick-borne illness. So I mentioned that it's present in a whole bunch of ticks, but you're not going to catch this from a tick bite like you might Lyme disease or Ehrlichia or Anaplasma. It's completely different. Typically, there are less than about 150 cases reported annually in the United States because for the most part, it's asymptomatic. Mild, nonspecific flu-like symptoms. Some patients will go on to develop a more severe course of disease with hepatitis, pneumonia. It can also be a somewhat rare course of subacute bacterial endocarditis, but that's pretty uncommon. And diagnosis is made by serology or PCR, and the recommended treatment for this one is doxycycline. So we do get some cases in the United States each year. You can see here on this map from 2014, as reported by the CDC, that there are places where you are likely to find it, but even then, it's not all that likely because you're only seeing about 150 to 180 cases. But some of those do go on to become severe or chronic disease. And actually, the hospitalization rate with this one is pretty high. You can see that in 2014, almost 70% of patients who were diagnosed with Querry fever were actually hospitalized. So it is something that if you encounter it may have somewhat of a severe course and patients may need to be monitored.